Okay, good morning. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thanks for joining us today for what is our 8th webinar as part of the fall SRS webinar series. This fall lineup does include 11 talks over 11 weeks. If you haven't already, I do encourage everyone to visit the fall.srs-webinars.com website to review the future talks that we have in store for you. And through this website, you can also register and to view recordings of the prior webinars as well. And one item of business before we get started, if you'd like to submit any typewritten questions at any point during today's talk, you can do so by using the Q&A button found at the bottom of your Zoom console. And time permitting, Dr. Tuleasca will answer your questions at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical. He's the inventor of the CyberKnife robotic radiosurgery system and Professor Emeritus of Neurosurgery and Radiation Oncology at Stanford University. Dr. Adler.
Thank you, Mark, and welcome everybody to one of our ongoing series of conferences, webinars brought to you by none other than COVID-19. But having said that, it is a unique honor to introduce today's speaker, Dr. Constantin Tuleasca, who hails from presently back in Lausanne, but Dr. Tuleasca is a Swiss-trained neurosurgeon who has worked with some of the luminaries in radiosurgery throughout Europe, particularly Dr. Levivier and also Professor Reyns in Marseille. He is trained with the best, and he has done research in multiple areas of neurosurgery, but especially in radiosurgery, winning a number of awards. I look at Constantin as the next generation of radiosurgical leaders, and it's a delight to be able to introduce him this morning as he's going to talk to us about AVM radiosurgery. So welcome, Constantin.
Hi, John. Good morning in the US. Thank you so much for your words. I consider you a pioneer in radiosurgery, and I think you did a great job, and you are doing plenty of extremely nice and interesting things. I'm mostly honored to speak today about radiosurgery for arteriovenous malformations and humbled for this invitation. Can anyone see my screen now?
I see it very well, Constantin. Looks good.
Perfect. So with this, I'm going to start. I would just like to say that for me, after 10 years of radiosurgical practice, I think AVMs are still a pathology where I take a lot of time to carefully analyze the imaging, do the planning, see the patients during follow-up. So I think it's a pathology which is not easy to treat by radiosurgery. It's not easy to treat neither by microsurgical resection or embolization. So I think it's a very nice topic. Now, I think one should start by discussing a bit natural history. You know, the hemorrhage risk in some publications is ranging between 2 to 4% per year. There is this formula which actually I like, and I actually tell the patient 105 minus the age during a lifetime. And you can see also that after a first bleed, there is an increased risk of rebleed, especially during the first year, which is further decreasing. These patients might have seizures, 1% per year mainly, and the risk of deficit, which is not low with each hemorrhage, which can arrive up to 50%. The mortality is also an important point, 1 to 1.5 per year. So how can we deal with these patients? I think we need to understand what's the age of the patient, what is his general status, wishes, circumstances of detection, and also we need to understand anatomical location, what is the volume, what is the architecture of this AVM, and what are the risk factors for bleeding. Of course, this is depending a bit also on the performances of the team, whether or not you have pluridisciplinarity, experience, or technical abilities. And you have advantages and limits of each treatment. Now, if we go, for example, to this recent paper published by Michael Lawton and Jason Shan's groups, published recently in Neurology, these are the main therapeutic options. Of course, there is simple observation, microsurgical resection, which allows the immediate cure with a moderate risk of morbidity, depending also on the angio architecture. You have the endovascular embolization, which is considered minimally invasive, but cures finally a minority of lesions. And you have radiosurgery, which induces a slow process. And you have also combined treatment. So mainly you have a multidisciplinary approach, and I think this is the key management of these patients. And now, if we go to radiosurgery, which is the subject of my talk, I think the early indications before appearance of brain angiography were limited by imaging techniques, mainly skull radiographs and cysternography. Now, we all know that angiography completely changed this problem and actually appeared before MRI. And you can see that in Karolinska, almost 30% of the activity, of the radiosurgical activity, were AVMs during the period 68 until 82. So this is quite important as number. Now, I think everything starts once you establish the indication with the target definition. I do a DSA in stereotactic condition, but I think if you don't do it in stereotactic condition, you still need to have one before you do such treatment. And we need to understand whether we have associated aneurysms, what is the exact venous drainage, and the afferences. All this is extremely important. If you don't do a good targeting, your result is going to be extremely doubtful. And this is a main problem. Of course, this is 2D images. And so I complete this with an MRI and an angioscan. So for me, multimodal imaging is mandatory. We need to understand the vessel's anatomy, but we also need to understand what is the brain anatomy in this area, in which area we are, what are the risks, and try to perform a targeting as much as accurate as possible. Now, once you perform the targeting, the question is what you induce in this AVM. There are several studies. Seifert pioneers several pathological studies, and mainly what we agree nowadays is that the first phase is of degeneration and proliferation of the vessel wall. This is mainly related to endothelial changes and damages in a disruption way, and also subendothelial proliferation. Now, the second step is conjunctive tissue changes, which is related to formation of granulation tissue, hyaline degeneration, and focal calcification. And finally, what everybody agrees is inducing a coagulopathy. Now, you did your targeting, you induced a radiobiological effect. So what would you expect? How you can define your procedure? And I think we can define it by 3 different factors. One is obliteration, which goes back to curing the patient. The second, which might be delayed, is radiation-related complications. And how can you anticipate this? And how can you treat them if you need to treat this? And the third is post-radiosurgical hemorrhage, which can appear or not at any moment after treatment. So finally, you have the balance between the chance of obliteration and the radiation-related complication. I also think that we had some early literature discussing AVM radiosurgery, which created some half-truths. Some call this myths, you know. It's like predefined ideas, which are maybe not extremely applicable nowadays, you know. And finally, one of the main problems, and I hope this is going to get better in the future, is that no study clearly reported the number of patients having AVM obliterations without new deficits. And this should be done by radiosurgical scores, either Pollock-Flickinger or the Virginia score, or by Spetzler-Martin, depending on cases. So let's briefly overview the main myths, and then we should advance further on other topics. I think the first one, and I hear this every week in my consultation, is that 80% of AVMs less than 3 centimeters will obliterate after radiosurgery. Well, this is not extremely true, because I think we need to take into account the age of the patients, and we'll go back to this, the venous drainage, anatomical location, and all these facts. So I think this is a little bit obsolete. It's like we say we don't treat lesions more than 3 centimeters. A second myth, which is also rather intriguing, is that the risk of radiation necrosis after AVM radiosurgery is 3%. That's again a fact which can be highly debated. And the third, although not last, is that bleeding risk after AVM radiosurgery is increased until obliteration. For me, that's certainly not true. And I think there is a lot of literature emerging now on this topic. Now, what do you tell your patient? How you can predict obliteration? I think one of the probably nicest paper in the AVM radiosurgical field is the one done by Pollock and Flickinger, discussing the Pollock-Flickinger score. That's a grading system which is actually discussing volume, the age in years, and the anatomical location. And you can see on the graph, the lower the score is, the higher the obliteration chances are. And not only obliteration, but excellent outcomes. So evaluating patients that come into our outpatients clinic using this score would give us an idea what are the chances of these particular patients to have an excellent outcome after radiosurgery. And this score has been further refined in 2008 and republished in Neurosurgery, a little bit adjusted, taking into account again the volume, the age, and the anatomical location. Beside this score, I haven't quoted it, but you have the Virginia score, which is also extremely nice and helpful in giving a fair information to the patient. Now, obliteration is certainly dose dependent. That's a fact which had been now proven during the past 30 years. This is a slide I borrowed from Dave Lansford in Pittsburgh, and you can see that obliteration is dose dependent. You have several curves, the red one, patients treated with less than 16 grays, the yellow one between 16 grays and less than 20 gray, and more than 20 gray, the green curve. And you can see also there is a time-dependent aspect. So these patients are not going to get cured, nor the AVM completely obliterated during, for example, the first months. So we need to explain this to the patient, that they need to wait. So there is a dose-dependent component and a time-dependent component. Now, we know this from other pathologies also, not only from the AVMs, that there is a balance. The balance is between the AVM obliteration and the risk of complications, which is again dose-dependent and I would say volume-dependent, depending on what type of AVM would you treat. And again, this is a slide I borrowed from Professor Lansford. Now you have here an example, and this is published back to 1996, that if you increase your dose from, for example, 13 grays up to 26 grays, you have a progressive increase of obliteration. Of course, between 24 up to 26, there is not much. So that's an important message. Again, there is a dose-dependent component, and we should provide therapeutic doses to a patient which has an arteriovenous malformations, which we treat by radiosurgery. These curves are important because they can give you an idea of the balance between the minimum dose provided and the obliteration, but also the balance with the risks you are taking. So now, that's a recent paper published this year, which I find it extremely interesting, discussing actually the size limitation in single session stereotactic radiosurgery for brain AVMs. And you can see here, this publication mainly is evaluating whether regular doses, 18 to 22 grays, or lower doses below 18 grays, analyzed retrospectively for different groups by volumes, which can go less than 5 milliliters to more than 15. The conclusion is extremely interesting, is that single session SRS could be acceptable for AVMs up to 20 milliliters if treated with ablative doses. And I actually like the term ablative doses. That's one of the reasons I chose this paper to share it with you today. Ablative doses is the dose need to cure your patient. So we don't need to do a compromise. We need to do a correct planning and cure the patient. Now you have the graphs. You can see that obliteration for less than 80 grays to more than 80, the p-value is not statistically significant. However, you can have more hemorrhage, for example, in the less than 18 grays group, and also more significant neurological events, while, for example, edema after radiosurgery is not statistically significant between the groups. Now, that's an important work we recently done. I say important not because it's ours, but because I always try, when I do something in radiosurgery, to show another view of the data. I think the dose, as we all know, independently of device, I did this work on a gamma knife because I work on a gamma knife, but I think in CyberKnife, in Linac should be the same. We deliver a certain amount of dose in a certain amount of time. So this parameter which takes into account this is the biological effective dose, the BED. This had been classically used in radiotherapy, and John Hopewell and the Oxford group made pioneering work on it. And we have been working together initially on trigeminal neuralgia during several years. And I actually took the data in Lille when I've been a fellow during the last year, before I'm getting back to Lausanne actually tomorrow. And you can see here, for example, we extracted patients with no prior embolization, no prior resection, no prior irradiation treatments, mainly Spetzler-Martin grades 1 and 2, a little bit of 3, no 4, extremely long-term follow-up up to 154 months. And what we have seen in these patients, in a vast majority of cases, they were treated at 24 grades, which is for us the therapeutic dose, at least in Lille, also in Lausanne. Almost 80% of the patient had been treated with this dose. And you can see the BED actually is varying between 106 to 246 in this cohort. You have several BED models. I don't get into details now. For several reasons, I decided for this paper to choose the beam on time, which is classically the basic BED model. And finally, what was interesting to see is that obliteration is function of BED. This is the BED curve and probability of obliteration in this cohort. And you can see it's extremely linear. And marginal dose and obliteration was not exactly the same, and this was not statistically significant. And actually, BED and beam on time were the key factors to predict obliteration in this cohort. So these were rather extremely interesting facts, let's say. We need to validate this in further other cohorts. And we established a radiosurgical score which predicts obliteration with a ROC area under the curve, which is 74%, which is quite fair. And again, age, which is also in the Pollock-Flickinger score appearing here, astonishingly, the V12 also, which might, and I will get back to this later, discuss a bit the balance between obliteration and complication. So with now, I'm getting back to the next parameter which might affect obliteration, and this is prior embolization. Now, again, this is, I would call it the fourth myth. We used to say to our patient, you know, you had an embolization, prior embolization, so you have less chances to get cured completely after radiosurgery. This is a seminal paper again from the Pittsburgh group, and you can see statistically significant p-value, embolized patients in yellow, no embolization in red, a quite significant difference, almost 17%. So this is a systematic review and meta-analysis published in Neurosurgical Focus in 2014. Again, the same information, prior embolization 41%, no embolization 59%, so again, statistically significant. And finally, I was extremely astonished to read earlier this year a study which is extremely nice. This is done by the Radiosurgery Research Foundation. And I think this is extremely important. I think not all the patients which had been embolized, and I will get back to this later on in my presentation, can be treated the same and can be told you have less chances to be cured because you had a previous embolization. So this study actually refutes the prevalent notions that AVM embolization negatively affects the likelihood of obliteration after SRS. Extremely interesting paper, fair number of patients, long-term follow-up, and I really enjoy reading it. You can see here that finally, if they compare patients embolized plus SRS versus radiosurgery only, the only statistically significant difference was a probability of hemorrhage, which is actually higher in the embolization plus radiosurgery group. Now, extremely important, and with this I finish the first part, which is related to obliteration, is radiation-induced changes. I think the V12 is extremely important. Of course, you can analyze this V12 in several manners. For me, I usually try to keep the volume of the 12 grays less than 10 cc. With this, I'm in the lower part of the curve. That's my gold standard. I think it's not the gold standard that should be applied to in any other centers, but it's just how I'm trying to analyze my planning, at least. And I think it's important because this V12, published also by John Flickinger and also Dr. Pollack and Dr. Kondziolka, was finally the beginning of developing a model to predict permanent symptomatic post-radiosurgery injuries for arteriovenous malformations. And again, the target volume and the risks. So these are the dose volume mesoeffective curves for 3% risk of brain necrosis from single fraction radiosurgery, again from John Flickinger. That's a recent paper published again by John Flickinger, which is analyzing actually how you can quantify this. And you can see the 7 years actuarial rate for developing persistent symptomatic post-radiosurgical imaging changes was 5%. And finally, the 12 gray was the only independent variables that correlated significant with such changes, while the symptomatic changes correlated with both 12 gray volumes in the AVM location. So again, the angioarchitecture, anatomical location, and the 12 grays. And this is a very nice paper, which is actually not much quoted and not much discussed. I think it has 100 citation or something, still high, but we need to speak more about this paper. Extremely nice, by Bengt Carlson, prediction of complication after radiosurgery for AVMs. And you can see the incidence of complications here, depending on the prescribed dose, and also average dose in 20 cubic centimeters and the complication rates. Again, extremely interesting paper, which can give you a clue about what's happening. Clinical material on 862 cases, extremely nice. Third aspect, hemorrhage risk. I think the nice studies I could find, the nicest study is this one, discussing that prior to obliteration, after radiosurgery, the risk of bleeding decreased by 54%, and after obliteration by 88%. That's an extremely important information to give to the patient. Now, to sum up a bit the first part of my talk, in radiosurgery for, I think, let's say, low-grade AVMs, which are Spitzler-Martin grade 1 and 2, this is a nice paper, part of the International Society of Stereotactic Radiosurgery Practice Guidelines. I'm not in favor of the word guidelines, but I think these are papers which can orient a bit the things by Chris Graffeo and Bruce Pollock and the ISRS board members, stating mainly that radiosurgery is safe, effective treatment for low-grade AVMs and may be considered as a frontline treatment, particularly for lesions in deep or eloquent locations. With this, I'm just going to say a few words about large AVMs and how can we deal with stage or with hypofractionated radiosurgery. So the main question is, how do we deal with radiosurgery with prior embolization, either in salvage radiosurgery or multimodality approach? Multi-stage radiosurgery, which can be stage volume and stage dose, or stage dose being nicely called hypofractionated or repeated radiosurgery. Of course, these two have different radiobiological effects, and this is extremely important to take into account. And of course, you have other multimodality management after incomplete microsurgery or radiosurgery followed by microsurgery. So how can you choose between hypofractionation or stage volume? I think this allows mainly to minimize the risk of complications. This is especially for large AVMs. You don't need to do this for low-grade AVMs, and you actually decrease the dose to the normal brain. Now, again, the rate of obliteration is reasonably high in series using stage volume radiosurgery. I will go back to this. This is, again, a myth which says that if you do stage volume, this is less effective. I think we should stop this. This is a question of dose and the volume you treat it. And also that hypofractionated radiosurgery also provides a risk of obliteration in recent series with high dose per fraction and the total dose taken into account. So independently of the technique, and I'm getting back to what I was saying about ablative doses, we need to prescribe a dose that is high enough to generate the desired biological effect, which is an induced coagulopathy in the case of AVMs. This is again part of multidisciplinary approach and combined strategies. So that's a case I borrowed from Alfredo Conti, my friend who is working in Bologna in Italy with a cyberknife. He is doing single fraction now for most of the cases, but this was a case where he performed fractionated, hypofractionated treatment. And hypofractionation exists now for several years, more than 30 years. Important thing is that we need to have a minimum dose per fraction. The cutoff is 7 grays. There are many studies discussing this. Obliteration can vary between less than 20 and up to more than 80%. So this is quite large, allowing to decrease radiation-induced side effects and longer latency period of obliteration, more than 5 years, because radiobiology is different. This is some of the pioneering series with conventional radiotherapy and intermediate fractionation. You can see number of complications at that time, not now, were extremely high. Now this had considerably decreased. And you can have here, courtesy of Penny Lee in the UCSF. UCSF made a lot of work on this topic also, and on stage volume concept. You can see mainly if you do 7 grays per fraction, 83% chances of obliteration. This is extremely high and extremely important. Higher complication rates, however, at least in this data. Now, again, you can see here, and that summarizes a bit the published literature: 7 grays per fraction, 83% chances of obliteration, 5 grays per fraction, 22%. So again, this is dose dependent, whether you are in single fraction or hypofractionated treatment. And you have here an example of a paper which had been recently published, which actually summarizes this data. If you want to see more detail, you can review the webinar afterwards and see the table more in detail, but it's more or less what I have said up to now. So that's a case we treated in Lausanne, just to have an idea of a stage volume. Now I'm passing to stage volume radiosurgery concept. And you can see we have treated a temporal AVM. This is the results 3 years later. Patient had an epilepsy before. It's not cured of her epilepsy, but she's getting much better, less number of crises, so more infrequent and less dramatic, let's say. Stage volume can be used alone or in combination. Target volume selection is important. So you have to have your anatomical landmarks, dosimetric software. Each volume session should be treated with a dose as optimal as possible. I'm getting back to the dose. I know I told you a lot of times during the webinar, dose is important. Obliteration rate 40 to 70%, this is important. And this actually allowed to decrease radiation-induced side effects of about 30%. Again, the drawback, longer latency period of obliteration. Usually I'm doing stage volume 6 months interval with an MRI before, just to see everything was fine, patient has no complication. These are some of the series, courtesy of Dennis Need again, and you can see that depending on the use dose, you can have obliteration rates which can vary actually. And so this is an evolving paradigm. And I think before, is what I was telling you before, we were used to say that such an approach yields 29% complication rates. This is era 1. And now we pass in era 2, where this complication rate is up to 13%. And so this is important. This paper by Michael Dermott summarizes that decreasing the AVM treatment volume, increasing the radiation dose per stage, and shorten the interval between stages actually is yielding better results, more obliteration rates, less complications. The rationale again for stage volume is reduction of the 12 gray volumes and allowing for interstage repair of sublethal damage. So again, this is back to radiobiology. And of course, again, a message, this is a recent paper on the same topic, dose is important and was strongly associated with improved rates of obliteration. That's again for, if you want to see afterwards the webinar, the main series published in the literature on the stage volume concept. In the interest of time, I'm not going to enter into much detail. So to summarize AVM radiosurgery, that's brain radiosurgery. I'm doing stereotactically. Of course, other devices are using it, are doing it using a mask. I think what's important is that AVM is not a tumor. So we need to have the anatomy, the angioarchitecture, understand the vessel topography, what are the afferences, what is the venous drainage. I think target definition is more difficult. This is certainly not a tumor. You need specific information and specific skills. If you need to discuss with a neuroradiologist, go, do it. It's better to do it before you target. I did this last Friday. It's important, it's interactive, and you get a better idea. Accurate definition of the nidus. Don't overestimate it. Avoid the draining vein, but not early drainage. You can also need to avoid peripheral angiogenesis to limit your volume. You need to limit the recruitment. You don't need to target this. Of course, this is more difficult after embolization, but this depends on what you receive as patient. You can have a multifocal partial obliteration. That's more complicated, need to take maybe 1 or 2 sessions to do it, but you have also sorry, my English is getting back at the end. So you need to be careful. You have this type of patient with partial obliteration, but a compact nidus, which remains at smaller volume, better dosimetry, and improved outcome. And this is my last slide, actually. Wait at least 3 years. Don't get hurry. You need to wait. The patient needs to wait. You need to do follow-up MRI. I usually do it on 6-month basis up to 1 year, then on yearly basis. And finally, I do an angiogram in the gold standard to confirm obliteration or failure if we need retreatment. And we need long-term follow-up MRI in case of complication development. With this, I want to thank you for your attention, and I thank Lausanne, Lille, and Marseille for being able to perform radiosurgery in these centers and train in these centers. Thank you.
Thank you, Constantin. That was a magnificent tour through a very complex topic. And I do think in the world of radiosurgery, nothing is more complex than AVMs. And it's interesting to see how the science changes, but it's also interesting to see how some of the most relevant data that you were showing dates back 20, 25 years. Yet I'm hoping the next generation is going to show us how to do this right. So I open the field to questions. These are pretty technical questions. I'd like to ask a few, and some things I didn't understand as well as I'd like to. So, for example, you said beam on time was a strong predictor, I think, of response or complications. And is that a correct statement?
Yeah, actually, we were astonished. In the study we published in the GNS with Lille, this was the first study, I think, where we found out that beam on time is statistically significant both for obliteration and complication appearance. And actually, the shorter the treatment time, the better the obliteration, but also the higher the complications. So I think beam on time will emerge as a parameter we need to adjust as part of the BED and biologically effective dose in the future.
So this is kind of a cobalt phenomenon in this case, right? So
yeah, I mean,
you're delivering, I think that wasn't so clear, but what you're trying to point out is that if you're delivering the same dose over a longer period of time, you're going to have a different BED.
Yeah, but I mean, I discussed this with Alfredo Conti, who is working in the CyberKnife, because I was intrigued by this, let's say, findings. And he was stating also that depending on how he's doing the planning by CyberKnife, he will have different treatment times, finally.
But yeah, I understand, yeah. So it is
you know it better than me with the CyberKnife, because you pioneered the CyberKnife, so.
We need better measures of instantaneous dose to a specific region of tumor or AVM.
Exactly.
And but that's a challenge to maybe us manufacturers going forward to see how, if we can't provide that kind of information. Okay, next question. Would you reduce the volume, would you reduce the dose to nearby eloquent cortex, motor cortex, visual cortex when you're doing your planning?
I do it. Usually I treat AVMs at 24 grays. This depends a little bit on the volume, of course. But if I'm close to eloquent areas, especially motor strip, thalamus, internal capsule, I usually decrease a bit the dose. Of course, there is no gold standard, or at least I don't have a gold standard for this, but I try to decrease a bit. I usually have two reflections. The first is decreasing a bit the dose if necessary, especially in larger volumes, because if I have a small volume, I usually don't care too much as related to the motor strip. But I try to see a bit what is my 12 gray. That's my second reflection. My 12 gray volume, if my 12 gray volume is safe as per Flickinger curves, I'm still staying to a therapeutic or ablative dose, and I try to have a good gradient towards the motor strip. But that's mainly, again, related to volume and the volume of the 12 gray particularly.
Perfect. So just want to talk about targeting here for a second. This relates to a question that someone in the audience posed both to me, but I'm going to pose it in part to you. You know, one of the biggest challenges technically with AVMs is trying to define a target from projection angiography. And you often need that temporal component of projection images to sort of get an adequate delineation of the nidus. So are you doing that through some sixth sense, or do you have a algorithm to correlate projection images to the volumetric data? And so that's kind of, what are you doing? How do you do that?
Yeah, thanks for this question, John. That's actually an important question. I've been started 10 years back my training in radiosurgery with Jean Régis, and he was not contouring any nidus, and he is still not doing it. And I was to perform AVM radiosurgery as other type of radiosurgical treatment without any contouring. I was seeing the angiography, try to imagine how would be the 2D projection on the MRI and all these things. And then I went back to Lausanne, and I actually changed a bit this. I'm not saying Jean is doing wrong. Huh? I'm just saying I changed my way of doing. And I actually draw the AVM on the AP view and on the lateral view of the angiography. And I have a 2D projection on my MRI.
Okay.
And then I'm contouring on the MRI. That's, I'm doing this, let's say not systematically, but I'm still doing it quite frequently. At the end is just to have an orientation, and finally I'm sometimes even deleting this draw, let's say, but I still have it. So to answer your question, I'm drawing on 2D, I project on 3D MRI, and then I do a volume, at least to have an idea where I am. But that's me.
But as you know, the AVM, different portions of the AVM will fill over time. So are you doing this with multiple projection images?
Yeah, I'm usually choosing an early image and a later one. I usually choose 6 images, usually 3 quite early, let's say, and 3 a little bit more late. Sorry, I didn't get your question from the beginning, but yeah, I'm trying to choose 6 static images at different time points during the angiography.
Gotcha. Okay. So I mean, we were just a shout out to some Stanford. Stanford has this pretty cool tool that directly maps the AVM images over time, projection images, onto the volumetric data from the CT using branching points of blood vessels. It's not protosized, but I do think and then the message to the audience is that the more effort you put into this, I think the more you can target just the AVM and not a lot of accessory, often normal brain.
Definitely.
So someone asked us as a company whether we perform image fusion of CT and angio MRI and rotational angiography image sets. And then the truth is, yes, all volumetric data sets can be fused with one another, including DSA with its accompanying CT. So I have a question. Why would you ever want to embolize an AVM?
That's a question which I adore most. That's probably the best question. I wouldn't. If you ask me, it's not I wouldn't. I would say it differently. As I was showing in my last slide, I think if you can completely cure at least one of the volumetric compartments of an AVM by embolization, that's not a problem. Because then the volume is decreasing, radiosurgery can be performed safe. You don't need stage volumes or other things. I think the problem is when you have small parts of the nidus a little bit spread all over it, which are cured. We cannot consider them cured. We can, let's say, obliterated. And you have, let's say, a big part of the nidus you should still treat by radiosurgery. And that's a problem, one, for the volume. Second, for the fact that I do believe that embolization products, casts, and all these things, onyx, will absorb part of the radiation. And you are prescribing a dose which is less effective. So you have a volume limitation, you have a dose limitation, and finally, you will need to do several radiosurgical treatments. So to answer your question, I think if one can embolize a compartment of the AVM which is compact, that's not an issue. The problem is when it's a lot of onyx everywhere, but you still need to target, and that's a problem.
Those are so much work. And I think that my own experience is you're not really sure that you're hitting the target.
Yeah, that's for sure. I agree.
So, I mean, I'll tell you, at Stanford, you know, the treatment of AVMs is more of a political decision sometimes. You want to give everybody a piece of the work.
It's everywhere political, John. I don't think it's only in Stanford. In Europe, it's also.
I know. But it's just nice to just talk to someone who has a similar experience. Okay, another question. Do you apply different treatment approaches for young patients, less than 21 years old?
When you say different treatment approaches, you mean surgery? And,
well, I guess there was an open-ended question from someone in the audience. You can take it as ever you want. I guess that is a good question. Would you now think more about surgery, or God forbid?
I think we have several issues. First issue is Aruba study, which is for me completely biased, induced some myths and some overthinking on some patients. That's typically the case of a young patient who has a small AVM, never bled, but is still a young patient, potentially high risk of hemorrhage during time. That's one issue. Second issue is that, at least for the moment, I worked in hospitals, in university hospitals, where we sit and discuss about cases. And we do this in multidisciplinary meetings. So we have neurologists, neuroradiologists, and microsurgeons doing vascular. So I don't have, let's say, at least at this point, a bias towards radiosurgery or towards microsurgery. I think we need to do a patient selection which is careful. That's extremely important. And I think we need to do also to give the patient the correct information of what's happening and what we wait for each of the procedures if several might fit. So this has not changed. I still see cases which are amenable to radiosurgery directly. And if I think we are always discussing whether microsurgery is more fitted, whether embolization could help decreasing the volume in a compact manner and all these type of things. So,
how about dose? Do you change a dose for younger people?
So for younger people, I never change the dose. For me, if I can prescribe 24 grays or as similar as 24 grays, I do it. That's my gold standard. It's how I've been teached to do it. I think after 24 gray, more than 24, we don't gain much in obliteration rates, but we are increasing complications. If we are close to eloquent areas, higher volumes and all these things, stage radiosurgery, we can decrease the dose. I'm trying to keep it as high as I can. I don't decrease below 18, never ever.
Okay, that's a good point. I think that's what the data shows. So here's someone here is really defending embolization here, and I'm proud they are. So they point out that embolization done well can really help the radiosurgery team, and that they, especially high flow patients, there may be a good reason to sort of want to do embolization. Certainly dural fistulas, I can imagine. That's another environment where I think embolization is very powerful. So, I mean, you and I have a little bit of a prejudice, I think, against embolization, maybe because we've seen it done so poorly so often. But I do admit that when done right, it can help radiosurgery as well. And I thank the person for asking that question. And I assume you would agree with those sentiments, correct?
I totally share your point. I think if we can be helped to decrease the volume to prescribe higher radiation doses, and this is performed by embolization correctly done, I totally agree.
Okay, well, I think we're going to wrap up here. This was a great tour, Constantin, of where we stand today in AVM radiosurgery. We're making progress, but I hope the next generation makes even more progress than the old guard, who I think is stepping aside. So keep up the good work, and thank you everyone for joining us this morning, and stay well.
Thank you so much, John, for inviting me. Really, all the best and much appreciated, and stay safe.
Thank you. Bye-bye.
Bye.